Today we're listening to Dr. Benzi Kluger, who will be presenting on cannabis research and complementary care, which involves other therapies that he'll be touching on. So Benzi is he's an associate professor of neurology and psychiatry and chief and founder of the palliative care section at the University of Colorado. And so I think hopefully most of you have listened to his topic early on, non-motor symptoms, and this will be a continuation of the therapies that we can maybe include as options for your care. So help me in welcoming Benzi.
All right, so thanks for inviting me out here. So I'm going to start talking about research on cannabis. And I think at the end there'll be time, and I'll talk a little bit more about complementary and alternative therapies more generally, including some thoughts I have about how to evaluate these therapies. I know for myself, I get asked questions nearly every day from people who've read something on the internet about stem cells or about coconut oil or turmeric and want to know if this is something that they should start doing. So I'll tell you about my approach to those kinds of questions. And then I heard that British Columbia, I don't need people to show hands, but it sounds like that there are at least a substantial number of people with Parkinson's who are using or thinking about using cannabis and would have access to cannabis through medical marijuana here. And so this is certainly a topic that would be of relevance to people. So I don't have any disclosures related to this work. However, I do live in Colorado, which, as I've explained to some people, has really become like the mecca of marijuana, I think, for the world. We actually have more dispensaries in Denver than we have Starbucks or liquor stores, which is pretty incredible. And another disclosure is that I do have long hair and a beard, which seems to be able to get me randomly checked every time I go to the airport, although I do not use marijuana on a regular basis. So learning objectives is to go through what cannabis is, and then related to that are cannabinoids and endocannabinoids. And I don't know if people have heard those terms before, but just want to go through to make sure that we're very clear on what the terminology is. I'll go over some of the basic science of cannabinoids for Parkinson's and other movement disorders. And really in the last decade and a couple decades, there's been a lot of interesting science around cannabinoids as something that's used in people and other animals for pain and sleep and other natural functions. And it's interesting that just like with morphine plant making opiates, and there's an endogenous opiate system called endorphins, that there's a similar thing with the cannabis plant, that there's a whole endogenous cannabinoid system of cannabis-like chemicals that are inside people. We'll go over what the current state of evidence is for cannabinoids as treatments for Parkinson's, and then I think it's also important to know what are the side effects of cannabinoids. So when I talk about whether things work or not, I think the more important questions is this something that's going to work for me? And the related questions to that is it dangerous? What are the side effects? What are the costs? And what is the evidence that it's going to help? So let's sign with my disclosure. Oops, let's see if we're going in the right directions. Yeah, so let's get started. So what is cannabis, cannabinoids, and endocannabinoids? So cannabis is just the overarching genus of plants that includes sativa. And sativa is a type of genus of cannabis that has higher levels of THC. So sometimes people kind of conflate sativa with THC, but it also contains other chemicals. Indica is another genus of cannabis plant and tends to have more cannabidiol or CBD. And ruderalis is another not very commonly used type of cannabis that also is more CBD than THC concentrated. Cannabinoids are any chemicals that act on cannabinoid receptors, which are specialized receptors in the nervous system, but also in the immune system that interact with these chemicals. And cannabinoid, as the name would suggest, are just chemicals that can be derived from a cannabis plant. So there are synthetic cannabinoids, which are man-made. There are phytocannabinoids, which means made by plants, and now there's over 100 psychoactive cannabinoids that have been extracted from the cannabis plant. So as you can imagine, it's getting more and more complicated to try to understand what the effects are of cannabis, since there are so many chemicals in a cannabis plant. And endocannabinoids are cannabinoids that are produced by neurons and other tissues in the human body. So the two most common phytocannabinoids that we talk about is THC. So THC is the primary psychoactive component in cannabis, and it's higher in sativa strains. And I don't know if people have kind of read these statistics, but there is an order of magnitude difference now in the percent concentration of THC in cannabis versus, for instance, in the 1970s, marijuana was typically 2 to 3%. Cannabis now, there are strains, at least in Colorado, that are 20 to 40% THC. So a lot more potent in terms of the psychoactive component. Cannabidiol, or CBD, is thought to be non-psychoactive and is thought to have more of a calming effect on the nervous system. I don't know if the same strains of plants are available here. There's a plant called Charlotte's Web, which is a strain of indica which has been used a lot for kids with epilepsy. And there's actually an increasing amount of evidence that CBD in particular may be helpful for certain types of epilepsy. And this has been an area of significant medical research, and it's higher concentration in indica and ruderalis. But it's important to note that all of the plant-based CBD products are going to have some THC, and they're going to have some mix of some of these other chemicals. And that can be an advantage sometimes, and it can be a disadvantage sometimes, depending on what you're trying to do with those products. Endocannabinoids, so these are cannabinoids which are based in people or in other animals. And the first one that was discovered is anandamide, which comes from the Sanskrit word for bliss, and it was discovered in 1992. And it's been shown to play a role in pain, sleep, and other behaviors, and also appears to be important in certain processes of brain and nervous system development. Also interestingly, it's found in chocolate, and may be part of the reason for some of the pleasant sensations that many of us experience when eating particularly concentrated and good chocolate. There's other endocannabinoids. There's something called vanilloids, like the word vanilla, that appear to be very important in the peripheral nervous system for pain, and may also be part of some of the analgesic or pain-suppressing properties of cannabis and cannabis-based products. Synthetic cannabinoids are completely man-made cannabinoids. The one that was first developed is something called marinol or dronabinol, and that is just pure THC. And that was initially developed for people with cancer to help with nausea and with appetite, but also has been used, and I've used it for patients before to help them with certain neurologic conditions such as Tourette's syndrome. Nabilone is really kind of a unique chemical that is a cannabinoid receptor. So these are the receptors in the nervous system, and this is a direct agonist of those receptors and has been used in a number of studies and is also being studied as a treatment for spasticity and multiple sclerosis and certain types of epilepsy. And then K2 and spice, these are, I would say, quasi-legal alternatives to cannabis. So these are kind of designer drugs, at least in the United States. They're typically available at truck stops and other types of locations like that. And they are actually fairly dangerous. So it's actually much safer to use regular cannabis and marijuana than these other legally designer chemicals, and they've been associated with a number of adverse health effects, including seizures, hospitalizations, and psychosis. So definitely things to try to avoid. So how does cannabis affect the nervous system? I don't know if people are able to see this or recognize these two people here. This is Cheech and Chong. So there's some smoke in the car, and Cheech is asking Chong, am I driving okay? And Chong's answer is, I think we're parked, man. And I bring up this slide for a particular reason. So there's a lot of hype around cannabis for Parkinson's disease. But if you think about the last slide and you think, and I'm not going to ask people if they've inhaled or anything like that, but if you think about people who are stoned, you know, do they move more or do they move less? Less, yeah. And it's known actually that if you stimulate cannabinoid receptors, that actually decreases the production of dopamine. So it's unlikely that cannabis and cannabis-based treatments at least a direct agonist at those receptors is going to be a big tool for helping people with Parkinson's disease, because the general effect of cannabis and a lot of the cannabinoid stimulations is to decrease movement. And that's been shown in a number of animal models as well, that it can worsen certain motor symptoms in Parkinsonian animals. That being said, as I talked about, there's over 100 different cannabinoids in cannabis, and some of those are agonists, which means that they increase the activity of receptors. Other of them are antagonists, which mean that they block those receptors, and then there are other things that are called partial agonists and partial antagonists that kind of act in between, and it really depends on the state of the nervous system how they're going to act. And so the use of plants is more complicated. The other thing that makes it more complicated is that cannabis can have effects that aren't mediated with the cannabidiol or the cannabinoid receptors. The CB1 receptor is the one that we're more interested in, because that's primarily located in the central nervous system, and it's particularly concentrated in the basal ganglia. So there's been a lot of interest in how this is relevant for movement disorders. CB2 is more prevalent in the immune system, but this is also important not so much for treating the symptoms of Parkinson's as potentially slowing down the progression. So as you may have heard about, that there seems to be an inflammatory or at least some immune component to Parkinson's disease. And so there's some thought that if we could modulate the immune system or decrease inflammation, that might help slow down the progression. So there's a tendency when using cannabis that it increases GABA, or gamma-aminobutyric acid, which is the main inhibitory neurotransmitter in the central nervous system. So GABA is also increased by alcohol and by benzodiazepines, so it increases sleep and decreases movement, and it can decrease dopamine release. As I said before, that cannabinoids are complex, that they may increase or decrease activity at CB1 receptors, that they have antioxidant effects. They're similar to things like vitamin E and coenzyme Q10. They have anti-inflammatory effects. There's been some newer research of the role of microglia, which are the immune cells inside the brain, and that these may be infected by cannabis. And there are also some cannabidiol or cannabinoid independent effects. And an example of this is the adenosine A2A receptor, which is actually a receptor that some newer drugs are being targeted for Parkinson's disease, and is also the primary site for coffee and caffeine to work on. In Colorado, it's interesting that when you go to a dispensary, there are strains of cannabis that can help you sleep, and there are other strains of cannabis that have more stimulant-like effects. And again, it really just depends on what is the mix of cannabinoids in that particular plant. So do cannabinoids improve motor symptoms in PD? People in this room may know this better than I do. I think this was in 1996. There was a gold medalist snowboarder. I think he was from Canada. Yeah, okay. People, yeah, okay. Who was really temporarily robbed of his gold medal because he tested positive for a performance-enhancing drug, which was cannabis. And I think most people who have used cannabis would say that that's not something that's, it certainly would not make me better on a snowboard, and it's probably not something that he utilized in his training or during his gold medal run, and so it was subsequently given back to him. So we kind of have this impression of cannabinoids, and yet when it comes to Parkinson's disease, we have this kind of almost opposite impression that they're going to help motor function. There's actually been some other kind of interesting, I'm trying to remember the name of the pitcher who pitched a no-hitter while on LSD. I'm trying to remember the name of the guy who was on the Pittsburgh Pirates. Yeah, Doc Ellis. Another example of a not typically thought of a performance-enhancing drug. He actually described his experience of pitching this no-hitter, and he said he was unable to see the batter during the whole game. So it was really a pretty remarkable performance. So in animal models, the published studies are pretty mixed regarding motor improvements. So there have been a number of studies that show slowing of animals, some that show enhanced animals. And one of the themes that I think we need to realize is that, again, it's going to depend on what type of cannabinoid they're using, and also the dose. CB1 antagonists, so things that block the cannabinoid receptors, seem to be the most consistently helpful, possibly through both dopamine and non-dopaminergic mechanisms in terms of improving movement. And both cannabinoid agonists and antagonists have been reported to improve dyskinesias in animal models. When we move to clinical reports, so clinical research is basically research done in people, there have been a couple of studies. One was done in Czechoslovakia, where they looked at Parkinson's patients, and 25% of these people responded that they used cannabis, and about half of them reported some benefit, including some with improvement of rest tremor, some improved bradykinesia, and some with improvements in dyskinesias. So this was all self-reported, and obviously in a self-reported trial, there's no control group, and there's definitely a significant chance for there to be some bias, namely that people who are using cannabis and it's working for them are more likely to report on their experience than people who have tried it and it didn't work for them. I also published a study from Colorado, and in our population, which was done a little bit more systematically, so this was just a random sample, it wasn't selected just by people who wanted to respond to the survey. Only 5% of the people in our clinic reported using cannabis. And most reported that they found benefits mostly for non-motor symptoms. So these would include things like sleep, anxiety, pain, nausea, and appetite. And that the benefits for motor symptoms were much more variable. That being said, I do have a few patients who are using cannabis and they feel like it helps smooth out some of their ons and offs and some of their motor fluctuations. But that's really the minority of people who I see in my practice. And all randomized controlled trials to date, and there now have been 4, have been negative. So when people have done trials where there's a placebo control group, they have been unable to show that there's a benefit from cannabis. And I would say that rather than calling them negative, it may be more fair to say that they were inconclusive because it really wasn't systematically done to find out what was the right dose of cannabis, what was the right mix of concentration in the plant. And so I think that there's really more research to be done. So I wouldn't take this to mean that there shouldn't be any more cannabis research and we know the answer that it doesn't work, but rather that the studies to date have been negative and there's more work to be done. We are actually doing a trial at the University of Colorado using high doses of cannabidiol to see if that would help with tremor. And I think the dosing thing is actually really important. So if you can compare the doses that we extract from the randomized controlled trials that have been published to the doses that are being done in epilepsy, again, there's an order of magnitude difference. So in the trials that have been negative to date, most of them have used 5 to 10 milligrams of cannabidiol, whereas in epilepsy, doses are from 50 to 100 milligrams of cannabidiol. And so it could be that it's the right compound, it's just at the wrong dose. So do cannabinoids improve non-motor symptoms in Parkinson's disease? I don't know if people are able to see this slide here, but it's showing a picture of the munchies. So there's really been no animal research. Well, that's not true. So backing up and tying into our first study today, there has been actually some interesting animal research regarding memory and cannabis. So if you look at it, and this was actually a grant that I put in that did not get funding, if you look at the research in people on cannabis, it's, at least last time I checked, which was a few years ago, the oldest subject in any cannabis trial was 30 years old. So we have almost no idea what cannabis does in people over age 30, despite the fact that that population is now actually the largest growing population in terms of use of cannabis, particularly for medical purposes. And there was a couple of interesting studies, one of which showing that cannabidiol, or CBD, may actually improve memory and increase neuronal function, at least in some animal models and at a small dose. And also that THC may improve memory, but only for older mice, not for younger mice. And it's interesting, the literature is very conclusive that smoking a lot of pot in adolescence is not good for your brain. But this research would suggest that that might not be the case for older adults. And so again, more research that needs to be done in people. Nonetheless, there's really been no direct studies of these symptoms in animal models, and there's been no randomized controlled trials. There are some case series, which means that it's just a report of a bunch of patients with no control group that suggests that there may be a benefit for REM behavior disorder. So this is the disorder I talked about this morning of acting out dreams. And also for psychotic symptoms, things like hallucinations, delusions, and agitation. in people with either Lewy body dementia or Parkinson's disease dementia. And both of those were with CBD or cannabidiol. There was actually, and not surprisingly, a negative trial of THC for people with dementia, and it made their psychosis and it made their other symptoms worse. And that's not surprising because that's kind of an expected side effect of THC. Our experience in Colorado suggests that there's benefits for appetite, for nausea, including nausea with medications, for pain, for anxiety, and also for sleep. And actually, before getting into side effects, I'll also just kind of tell you how I usually work with patients when it comes to these compounds. So I think in British Columbia, like in Colorado, the way it works is that you can get a license to go to a medical dispensary, but you don't get an actual prescription. And the first thing to know, and this is true in Canada, and it's true in the US, and true in most places in the world, when it comes to alternative medicines, and cannabis would be an alternative medicine, there's no regulation of any of those products. So if you, for instance, have been using a product that says 10 milligrams of CBD and you've been getting it at Smokey Joe's, and then you go across the street to Super High Me and get something that's 10 milligrams of CBD, you might have a very different experience. So one thing that I advise people when they're working with cannabis is to try to find a dispensary that they know and like and that they trust, and to stick with that dispensary and stick with those products. A second thing is to start with a low dose and to go up slowly. And again, that's because we don't really know what the dose is of whatever the product is that you're getting. Third thing is to try to utilize the way that you take the cannabis depending on the symptom that you're having. So for example, for people who are having pain, including dystonia, a lot of times what we'll do is start with either a cream or a patch, which can be very helpful for pain and tends to have less of the systemic side effects of dopiness and other things like that compared to oral or smoking. THC seems to be more helpful for nausea and appetite. So if that's the target symptom, then having a product with more THC may be more important than CBD. On the flip side of that, for things like sleep, CBD may be more helpful than THC. We generally recommend when people are taking it orally to use either drops or candies or things like that to avoid smoking, which can have effects on the lung and the vocal cords. The disadvantage of the oral products is that a lot of times the absorption is harder to predict in terms of timing as well as in terms of dose. So I do have some patients who will use either a vape pen or something like that to get kind of targeted hits to help smooth out certain symptoms. So we really want to make sure that we're using the right product for the right symptom, and also that we have a target symptom. Some people have been interesting or asking me, should I start using cannabis for marijuana, for my Parkinson's? And I've asked them, well, what are you trying to treat? And they're just like, my Parkinson's. And so, at the current time, there's not any evidence that it helps Parkinson's in general, so we really want to make sure that we're targeting symptoms that we think might be helped by it. And like I said, the non-motor symptoms are the ones that I'm the most familiar with. It's certainly possible that we might be able to smooth out some things with cannabis, but it's unlikely for the reasons I discussed earlier that you're going to be able to get off of your dopaminergic medications like Cinemat and just take cannabis, particularly since cannabis really reduces dopamine production. And so it wouldn't really be expected that you'd be able to get off of all your dopamine medications and just replace that with cannabis. The most common side effects that we see, so not surprisingly, one of them is cognitive. And so in older adults, we've had a number of people where thinking and memory problems have come up. Again, tying back to this morning, apathy or problems with motivation certainly could be made worse by cannabis, which is not surprising. Dizziness and falls and also low blood pressure have been reported side effect in clinical trials from cannabinoid medications. Both. Yep, both THC and CBD. And in nausea is another side effect. And actually in the cannabidiol study for tremor, when they were doing their dose finding thing, that dizziness, nausea, and feeling dopey were all side effects that did come up at the higher doses. So it looks like even though the word on the street is that cannabidiol does not have those effects in people, at higher doses it certainly can have those effects. Smoking may increase the risk for cancer and other pulmonary issues, so something to be careful about. And as I said, edibles may have less predictable absorption and are a little bit harder to dose. So can cannabinoids slow down the progression of Parkinson's? And this was a book I found online of cannabis for cancer and other common illnesses, the medicinal benefits of this miracle herb. And so it really has been hyped as a miracle treatment for a number of things. And for some things it really does appear to have some impressive properties, but not so much for Parkinson's disease. So in preclinical models, so in animal studies, there's been a number of studies that suggest that there's neuroprotective effects in toxin-based models. And this will kind of tie into what I talked to you about with complementary medicine, but it's really important to know when you're kind of reviewing things and you get a newsletter or something on the internet, or your daughter or son tells you something that you should start taking, that if it comes from an animal study, you really have to take that with a grain of salt. So with Parkinson's disease, the animal studies are mostly done in toxin-based models. So one example of that, there's something called MPTP. Have people seen the documentary called The Frozen Addicts? Anyone by chance? So The Frozen Addicts is a documentary about people who are using a synthetic form of meperidine, and again, this designer drug, they did something wrong when they were making it in their basement, and it turned out that that toxin actually caused a very acute form of Parkinson's disease. And MPTP is actually the most commonly used model now for animal-based Parkinson's, but most people do not have Parkinson's disease because they were taking a synthetic opiate. And so there's some problems with the toxin-based models compared to actual Parkinson's disease. There are also now a number of genetic models, but these are also limited because only about 15% of Parkinson's disease can be tied back to single genes. And so it's not clear that things that work on the genetic models are necessarily going to work in people. And just like anything else in research, there's also bias in these studies. So if people did a cannabis study and it was negative, so they gave mice, had them smoke 5 joints a day and saw if their Parkinson's got better, and their Parkinson's didn't get better, they might decide not to try to publish that study, or they may have a harder time getting that study published. And so there's always a bias in the medical literature to suggest that things work, even if those things may or may not work. So that's something to be aware of. Nonetheless, there have been a number of published studies that suggest, and a lot of them were actually well done, that suggest that there may be some neuroprotective effects of cannabis and cannabinoids, and the mechanisms are likely not related to the cannabinoid receptors, but have more to do with anti-inflammatory and microglial properties, and there are so far no data in people. So for this first part of my talk, the take-home messages is one is that there are a number, dozens of psychoactive chemicals in cannabis, and products derived from cannabis may vary pretty widely in terms of their benefits and side effects. The other thing that I will also mention here, and this is also just anecdotal, is that it seems that for a lot of people taking plant-based products, they've had better effects than using the synthetic products. And that may be because in the plant-based product, there's a mix of all of these different chemicals, and they may help balance each other out, whereas in the synthetic products, they really just have a single chemical. There's currently no conclusive evidence supporting the benefits of cannabis for anything in Parkinson's. That includes motor and non-motor. So the data that I've presented to you is also anecdotal and needs to be validated in placebo-controlled trials. Nonetheless, it does suggest, and my experience has been, that it may help things like pain, sleep, appetite, nausea, and anxiety. The research on motor symptoms and dyskinesias in people has been negative, so all of the clinical trials have been negative. The uncontrolled case reports have been positive, and I would say as a whole it's really inconclusive and there's a need for better studies. And then it's important to know about the side effects, which include confusion, low blood pressure, falls, and pulmonary issues if smoked. And I'm going to, actually maybe before I switch gears, I'll take about 10 minutes to answer some questions about cannabis, and then I'll talk a little bit more generally about other complementary medicines, and then we can kind of end with another round of questions. So any questions specific to cannabis? Yeah?
Yeah, I just wondered if you took the CBD for sleep over time, 1 or 2 times, then it might not make a difference. But if you took it over time, I would gather from your comments that there's been no research done to know what the long-term effects would be.
Right. Yeah, so the question was using CBD or cannabidiol for sleep, if there's any evidence on the long-term effects. And there is not in people. So we don't know, and this is actually studies that I've wanted to do, and I think there's a big need for it. Is particularly in older adults, is there any evidence that it may affect thinking and memory over the long term? There does not appear to be, compared to things like opiates and benzodiazepines, any evidence for developing tolerance or addiction, which is a good thing. But we really don't know, kind of the longer term effects of using CBD. So that's another potential risk. One thing that I will say to that is that for a lot of the patients that I see, particularly in our palliative care clinic, that they feel that the side effects of cannabis and cannabis-based products are oftentimes less than benzodiazepines or opiates or narcotics. Yeah.
I understand that you're from Colorado, but we have such a bad epidemic here with fentanyl now in drugs.
Mm-hmm.
How safe is the marijuana that you would buy at a dispensary?
Yeah, so the question is about the safety of the products that you buy at dispensaries. And I can't speak for British Columbia. I could say in the Colorado experience has been generally positive, and part of that is that by making it a legitimate business, that people really want to get return customers. And so I think the quality of the product has risen, that the consistency of the product has gotten higher. The chances of it being spiked or other things is really almost non-existent because, again, people want you to come back and to continue using their shop. That being said, there's no regulation, and so there's a mix. There's actually a person who I work with a lot who's on our campus who has cannabidiol, and he always tests it for pesticides and other toxins. So that is a potential danger with using it, and he also does testing to make sure that the dose of cannabidiol and THC are consistent. And despite the labeling, there's really no way to know if those labels are accurate. So that is a potential risk, and unfortunately, until we get better regulation for alternative products, it's something that we really just can't get around. Yep.
We have one more over here.
Is there a difference in the CBD found in indica versus what's found in hemp?
Yeah, so the question was, is there a difference in the CBD found in indica versus hemp? And so CBD or cannabidiol, whether it's man-made or from sativa or indica or hemp, would be the same chemical. I mean, that's how the cannabinoids are derived. The other chemicals that are with it would be different, and so the effects of CBD and sativa may be very different, for instance, than the effects of CBD and indica, just because of the other, a lot of them were just poorly described or poorly measured cannabinoids that may go with it. But the CBD itself would be the same. Yeah. Okay, yeah.
So apparently you don't get the same feeling with sativa and indica.
Right, so the question was that you don't get the same feeling with sativa and indica, and in Colorado, and I'm sure that the same thing is true here, if you go to a dispensary, that there are now so many strains that even within sativa and indica that there's going to be a lot of variability. But just sativa and indica would be, that sativa would tend to, is used actually more in our kind of recreational dispensaries and is more, it has high THC, has a little bit more stimulant properties and things like that, whereas indica is going to generally be more calming. But there's going to be kind of varieties in both.
So I have a store right near where I live, and I don't need just walking, buy what I want. And there's a young man there one night, said, "What is that?" That's the tea there, and
Didn't know.
but I said, how can you run this place?
Yeah, so, and just to kind of briefly summarize the story that, and this I'm sure again is true is in Vancouver and British Columbia and Colorado, is that not all dispensaries are created equally. So it's not like going to a pharmacy. So there are some dispensaries that the people working there have a lot more medical knowledge than others. And so just kind of like my comment with taking time to find a therapist, it is worthwhile, either talking around. Oftentimes even in Parkinson's communities, there may be some knowledge about which dispensaries tend to have more experience with medical things than others.
Can I say one more thing?
Sure.
There was a man on Facebook, you might have seen it, he had really bad dyskinesia, and he was given some hash oil, and it shows him just calming down.
Yep.
And I get so many people sending that to me,
Right.
and I tried it, didn't do anything.
That didn't do anything, yeah. And that actually will tie into kind of the next portion of the talk.
Yeah.
Or do you have another comment?
No, just on another comment in terms of, finding out if you are interested in cannabis products, finding out like where you can get them that are more legitimate than others. There are obviously dispensaries that in Vancouver and in British Columbia that exist and have like a chain, and they're like a bigger organization. There's a help sheet on your tables, and if you haven't received one, it's called Accessing Medical Cannabis in Canada that we put together, and it's about the legalities and maybe what you're looking for in terms of getting actual medical marijuana in BC versus just going to a dispensary which may not have the same regulations, probably doesn't have the same regulations, so you're getting a product that is more reputable.
Okay, thanks. Yeah, so the last comment, and actually ties really nicely into the other thing that I wanted to talk about, was this woman mentioned that there's a video going around on YouTube of a person with bad dyskinesias who I guess smokes or takes a little bit of hash oil or oral, and almost immediately their dyskinesias go away. And I think it's a good transition because it's a really good example of what we call anecdotal evidence. So anecdotal evidence is kind of informal evidence, and it's personal stories and experiences, and there's a lot of room for bias there. So in talking about complementary alternative medicine for Parkinson's disease, almost everybody, so over half of people with Parkinson's disease will engage in some form of alternative medicine. And when we talk about complementary alternative medicine, that really refers to anything that your doctor does not prescribe. So that could include cannabis, it could include certain exercises like Tai Chi and yoga. It can include physical therapies like massage. It can include other alternative treatments like acupuncture and herbs and vitamins. So alternative therapies are used pretty widely by people with Parkinson's. And people with Parkinson's use them for a number of reasons. So alternative therapies, they give you an alternative to taking medications. We actually recently published a study, and I don't know if people can relate to this, that a lot of patients have stopped telling their doctors about certain symptoms because they've recognized that there's this formula that anytime they bring anything up, like my nose itches, they end up on a new medication. And so alternative therapies, for a lot of people, is more consistent with their values, and it provides them with a way to treat symptoms that don't involve another medication. A lot of alternative medicines may have less side effects than their medical alternatives. It gives people a sense of control. There are certain symptoms, for instance, fatigue is a good example of this, where there are really not any great evidence-based treatments, and so people are looking for other things that can help them with their fatigue. And lastly is that, particularly with an illness like Parkinson's disease, I think a lot of people are looking for hope, and they want to do something that's going to cure their Parkinson's or make it better, and that their doctors are telling them that they don't have anything more that they can offer. On the flip side of that is there's a lot of downsides to complementary alternative medicines. The major one, or one of the major ones, is that they just have not been well researched. And I want to make it clear that I'm not against alternative medicine. So an interesting story, Ayurvedic medicine, which is the medicine native to the country of India, had a diagnosis, I don't know how to say it in Sanskrit, but basically was the shaking palsy or Parkinson's disease, and it was described a good 2,500 years or 3,000 years before James Parkinson wrote up his first patient. Also interestingly, in Ayurvedic medicine, they have been using mucuna, or deer's eye, which is a kind of bean that contains high amounts of levodopa for thousands of years. So in this alternative medicine system, they've been using levodopa to treat Parkinson's disease thousands of years before we had Parkinson's disease or discovered dopamine. So I don't think that all alternative and complementary treatments needs to be thrown away, but I do think it needs to be researched and looked into further. A second huge issue, and this ties into what we talked about with cannabis, is that it is not regulated. In the United States, the New York Attorney General is actually, interesting and not surprising. So General Nutrition Centers had a huge letter writing campaign in the 1980s, actually one of the largest letter writing campaigns in history, to get the FDA to not touch your supplements. And this was their big push, and they were successful in it. And now, 20 years later, when we've looked at supplements from General Nutrition Centers, in general, they found that the supplements contain 0% of what's advertised on the supplement, and that the two top ingredients are rice powder and houseplants. And this is true actually for supplements across the board. We talked about mucuna, and there's actually some interesting data that suggests that mucuna may actually have slightly less risk of dyskinesias than levodopa, and that may be from other things that are in the plant. But unfortunately, I worked with or talked to a researcher in Tampa who does mucuna research. When he investigated mucuna products that were available, and he looked at, I think, like the top 5 sellers from Amazon, none of them contained any levodopa or mucuna. So even though that there's some great promise there, there's also great perils. And that makes it very difficult to be able to work with these kinds of products, is because it's hard to find high quality products. Other things that I think that can be harmful is that a lot of these products create a lot of false hope. And so one of my actually least favorite quotes, I don't know if people have read the book Love, Medicine, and Miracles by Bernie Siegel, but there's a quote in there that says, "There are no incurable illnesses, only incurable people." And I don't know how that strikes a room full of people with Parkinson's disease, but to me, I really wanted to punch that guy in the face. Because I think one of these threads that's through this alternative medicine and some of the complementary communities is that if you were just pure enough or prayed hard enough or had the right attitude, that you'd be able to cure your Parkinson's or your Alzheimer's or your cancer. And I think that there's a lot of harm to patients and a lot of harm to families that comes out of that kind of thinking. Then the last thing that is also dangerous about that is that it's really important to view these things as complementary medicines. So when I talked about cannabis, I talked about cannabis is likely to decrease dopamine, and so if you use it, you should still use it in concert with your other medicines. And I've unfortunately seen some tragic cases of people who are really wedded to an alternative medicine system and have suffered, I think, needlessly because they did not want to do DBS or Cinemat or any of the other medications that were proven and available, and were really wanting to do just homeopathy or other alternative treatments, and I think really had worse outcomes, more disability, and probably died sooner than they would have if they used complementary as opposed to alternative treatments. So when I get these requests for should I get stem cells or should I get whatever, I'll kind of work with people. I don't have it in this, but I have a slide that says how to recognize BS, and I put it in parentheses, bad science, but I'm also referring to bullshit. And that there actually is quite a lot of dangerous and expensive bullshit out there that is being pushed on patients, and I think on vulnerable populations. So some of the tips that will trigger me, one, if a treatment claims to be able to cure everything or nearly everything, that's always a red flag that it probably can't do anything. If people claim to be an expert who no one's ever heard of before, or who is an expert only on the basis of the results of a book that they've written, is always a red flag. If you look at the evidence that's presented and it's all anecdotal, so it's all quotes and case stories and things like that, and there's no actual scientific evidence presented, that's a red flag. A lot of times these websites will have scientific evidence, but it comes from strange journals. For instance, like the Indiana Journal of Agriculture and Parkinson Science or something like that. Or it may have just to do with an animal study, or a lot of times it's not even related to the claim that's being made. So if you dig a little bit deeper, you find that the science that's presented is not very good. There's also been a trend that's kind of interesting in terms of using scientific language to be able to sound more sophisticated. And if you look at the history of snake oil, so snake oil was an actual product that was offered at the Chicago World Fair in 1890, but things have really changed over time. So after 1890, there was a lot of excitement about electromagnetism, and so there were a lot of magnetic-based treatments. In the 1920s and 30s, there was a rise of hormones, and it was the discovery of testosterone and insulin, and so there was this thought that hormones were going to cure everything. And there's actually a great book called Charlatan that was about the greatest charlatan of all time, who was also known as the goat gland king. But he made millions of dollars during the Great Depression by selling people a goat gland cure where he took a goat testicle and implanted it into a person. And again, using this language of pseudoscience and hormones that made sense at the time. Then the next wave was the vitamins, and different vitamins were discovered. And the latest thing is stem cells. So there's a lot of excitement about stem cells, and there's a lot of advertisements, particularly outside of the United States, for using stem cells for various things, but there's really no scientific evidence to back up those treatments, and there's good scientific evidence to suggest that they're dangerous. and that there have been a number of cases of cancers in the spinal cord and the brain from people who have gotten these spinal stem cell infusions, that those cells have actually grown in the brain and have caused problems, but there's no scientific reason to suspect that putting stem cells in is going to cure Parkinson's disease. It's kind of like thinking that you're going to be able to fix a car by throwing a bunch of nuts and bolts in the engine. It's very unlikely that that's going to work. So my approach when I'm working with the patient is I'll kind of go through the literature. A lot of things there are some evidence for. So Tai Chi is an example of an alternative treatment where there's been good randomized controlled trials showing that Tai Chi is actually even better than regular physical therapy for balance and quality of life. There's some evidence for yoga and massage, Feldenkrais, for melatonin. The evidence for acupuncture is mixed. So I actually published a study on acupuncture for fatigue and Parkinson's disease and looked at one way acupuncture worked. So people in our study, about half of them reported that they noted a significant benefit in terms of their fatigue. And another way it didn't work, namely that acupuncture was no better than the placebo acupuncture. And this is going to be true for a lot of types of alternative therapies, is that, and in the case of acupuncture, you know, the people in the placebo group, they still came in twice a week, they still had to relax, they still focused their intention, and so the placebo wasn't entirely a placebo effect, there were also other non-specific effects. There's some increasing evidence for meditation and mindfulness for Parkinson's disease. There's certainly evidence for using alternative things to help things with like constipation. There's things for exercise for fatigue. And so there's a lot of good evidence for things for Parkinson's. And there's a lot of things where there's absolutely no evidence at all. And that would include turmeric, coconut oil, some nutraceuticals that are out there where we really just have not done any good studies. And then there are a few things where there's actually good negative data. So coenzyme Q10, creatine and vitamin E, they have all been shown in large randomized controlled trials to not be beneficial for Parkinson's disease. So my usual take when talking to patients is we'll look at the evidence. If there is evidence, then we'll go with evidence. But if there's not evidence, then we'll kind of go over, is it dangerous? And there are a number of herbal supplements that have drug interactions or that have side effects. And so that's an important thing to look for. And then if it is safe, is it worth the cost? And so for some things like coconut oil, or like as I mentioned this morning, put a bar of soap under your pillow, that you know, is fairly cheap and safe. Other things, you know, I have some patients actually, you know, just last week who was saying that their husband was spending hundreds of dollars a month for supplements, and that it was actually becoming a significant financial drain for them. And again, we have to kind of take a step back and see, you know, what is the evidence for these supplements. And for me, you know, oftentimes makes me angry that I feel like, you know, supplement companies and other people are really taking advantage of people with Parkinson's. I don't know if this one's been going around the US, but there's been, I'm trying to remember the name of the doctor who's had to claim that there's a special blend of amino acids that he's developed that can help cure Parkinson's disease. A while ago, there was this thing about grain brain and trying to be on a high-protein diet, but there's really no evidence for any of those systems. There's actually no evidence for any specific diet for Parkinson's disease. And so it's 3:30 now, and so I will leave 15 minutes for questions on any complementary alternative medicines, and I'm also happy to answer questions on other motor or non-motor or other things with Parkinson's if they're kind of some free-floating questions from this morning.
Earlier you mentioned turmeric as a dietary benefit.
Yeah, so turmeric would be an example of something where there's been a couple of animal studies. This is actually true also of cinnamon. I think there were a few other things that have been floating around. And there were a couple of animal studies suggesting that they may have anti-inflammatory properties, but there have been no studies in people. So this would be an example of something that I think would be safe, it's cheap, and it's tasty. And so it's really up to people to use their own judgment about whether that's something they'd want to incorporate into their life or not. But there's not any good evidence in people. And my suspicion is actually right before I started medical school, I worked in a nutrition lab and did a lot of research in nutrition. And I'm overall more skeptical than hopeful for a lot of the things that come out of the nutrition world in terms of supplements and things like that, for ever being able to show a significant benefit for people.
Any other question? Oh.
Yeah.
Have you heard of something called marine, and it's supposed to be a natural levodopa, a neuroprotective.
No, I haven't heard of that.
This was something that's coming out of the Netherlands.
Okay, so apparently, and I'd be happy to look it up. There's something called Entre Marie that's supposed to be a natural form of levodopa and to be helpful. And there are, in addition to mucuna, so fava beans, which are things that you can actually buy at the grocery store and eat, also contain dopamine and levodopa. And so I don't know about this particular supplement. One thing to know, and this goes back kind of the history of, and actually the movie Awakenings. So before there was Cinemat, and the word Cinemat means without vomiting, there was just levodopa without carbidopa. And carbidopa prevents peripheral conversion of levodopa, and it reduces nausea, but it also increases the amount of levodopa that gets into your brain. And so originally when people were using just levodopa without carbidopa, so our typical dose is that you might take, let's say 325-100 tablets a day, which is 300 milligrams of levodopa. When levodopa was given without carbidopa, the typical dose was 3,000 to 5,000 milligrams a day, 3 to 5 grams per day. And so one thing is that I don't even know if it's humanly possible, particularly for people later in the disease, to eat enough beans to get their levodopa levels up that much. So that's certainly one thing, is about the conversion. Second thing, as I mentioned, is trying to find reliable sources, which, unless, and I'm not aware of, I actually got a question last week that somebody seemed to suggest that Switzerland might have some regulations, and that would be something you'd have to look into to see if they have more tight regulations around labeling and things like that than the United States or Canada does. But yeah, I would kind of take it with a grain of salt and be skeptical of it, particularly if it comes with a high price, and particularly if the research behind it is all done by the people selling it. Yep.
I have two quick questions. What kind of bean was it you said that they were using in India for the Parkinson's? Mm-hmm. Is that faba beans?
No, in India, so in this Ayurvedic medicine, there's something called mucuna, M-U-C-U-N-A, mucuna pruriens. And that is, it contains, it's also known as deer's eye in Native American medicine. And it contains a high amount of levodopa proportionally, although again, it's measured in milligrams. And it is something, it's one of these things that I really think that there does need to be further research, and that there may be things that we can learn from that, because at least in some of the animal studies of mucuna, it looked like the risk of dyskinesias were possibly lower than using synthetic levodopa. But again, it's really hard to find high quality product. And the other thing is that it's actually hard to do research because these things are not going to be funded by pharmaceutical companies. And they're also not going to be funded by supplement companies who actually, I think, benefit from there not being science. And would probably rather that people don't find out what the truth is behind whatever product it is. They don't want to make that investment. They're not really interested, I don't think, in helping people. They're much more interested in trying to sell as much of their product and making as ridiculous claims as possible.
Okay.
Yep. Okay.
And the second question, I may be kind of naive, but would you say again what this business is about, the bar of soap in the bed?
Yeah, so the business is in the United States, and I've given a lot of talks in the United States, and I'd actually be interested in a lot of support groups. There is this story that's been spread around that putting a bar of soap under your covers helps with leg cramps. And it doesn't make a lot of sense to me, but I've had hundreds of people who swear by it. And that would be an example. We could do a randomized controlled trial where I guess we have a bag and there's either a rock or a bar of soap in it, and we see what happens. I don't know that that's really necessary. If doing that helps, it's cheap and it's safe, so why not give it a try? Yeah. Yeah, I'm glad you asked that. So the question is about placebo effect, and the placebo effect in Parkinson's disease and placebo in general is very interesting. A placebo effect in Parkinson's disease, so that has been shown in studies that people with Parkinson's can increase production of dopamine in their brain by up to 40% with placebo. And there have been a number of studies of very sophisticated treatments, including stem cell implants in the brain, or fetal cell dopamine cell implants, of gene therapies that were surgically transplanted. And in the phase 1 studies, where there was no control group, they looked great. And when they did the placebo-controlled trial, they turned out that all of the benefit was placebo effect. And there was actually a very controversial trial of something called glial-derived neurotrophic factor, or GDNF, which was shown to be a placebo effect. And patients were demanding and actually suing the company to be able to continue getting GDNF because they felt that the benefits were so great. And the placebo effect is also interesting. So in our acupuncture trial, and this goes to the GDNF experience, that I had the kind of naive idea that people who were getting placebo and had a benefit, that at the end of the trial, I would say, oh, I fooled you. You were getting placebo. You can fix the fatigue all on your own now. And that's not what happened. So people who were in the placebo group who got benefit from placebo acupuncture needed to go back to get real acupuncture in order to maintain their benefit. And you can tell people that they are getting a placebo and still get a placebo effect. And so it is not something that's so simple as it just being conscious expectations. And there are different factors that drive the placebo effect. So there are biological factors. So in the pain literature, if you block opiate receptors in the brain, you block the placebo response. So there's a biological effect to that. And I would believe if you did the same thing in Parkinson's, you would block the placebo effect if you block dopamine. There are interesting psychological effects, and the best study is on like Pavlov's dog of conditioning. And so in animals, you can take a mouse, give it an immunosuppressant, and put it in a room with a red light, and over time, if you put the animal in the red light room, it will suppress its own immune system without drug. And so the part of the idea behind placebo response is that if you see, doctors or take pills or surgeries, that becomes a cue that your body needs to start healing itself. And so there's this aspect of it. And then the last thing is that there are some very strong cultural components. So in Brazil, for instance, pink pills have a higher placebo effect. In the United States, blue pills have a higher placebo effect. And so there's kind of these strange cultural idiosyncrasies that are also driving placebo effect. But it's important to note about that, because when you see these anecdotal reports, a lot of that may be just driven by placebo, and there's nothing magical about the stem cells or the pot or whatever that people are trying to sell you. It's just that they've hand-selected people who had a good placebo response to whatever it is they're selling.
If I take medication 3 times a day and then take a night dose, when should I take the calcium and what's the other one? Vitamin D?
Yeah. So calcium and vitamin D don't interact with Cinemet. And so you can take it at the same time. You can take it with breakfast. It really doesn't matter for calcium and vitamin D.
Yep. We have one last question here.
Hi, I just wanted to ask about the possible benefits or downside of chelation therapy, which is meant to remove heavy metals from the blood, on the theory that heavy metals are bad for the brain.
Right, yeah, so that's a good question, and actually ties to kind of a related question a woman was asking this morning about Lyme disease. So there is, and again, this has to do with the fact that, people who I would call charlatans have gotten increasingly sophisticated over time. And so there are now a number of people who will run lab tests to look at heavy metals, to look for Lyme disease, also to measure neurotransmitter levels. And then they will take the results of this test and they will sell you a special proprietary blend of amino acids to get your neurotransmitter levels right. They will offer chelation therapies, including taking mercury fillings out of your mouth and things like this, or to give you chronic treatments for Lyme, which may be herbal-based or antibiotic-based, but there is no evidence for any of those things when it comes to Parkinson's disease. So my advice would be to stay away from those treatments.
One more.
A quick one from this morning. You mentioned there are medications for drooling. Would you mind naming one?
Yeah. So the question was about treatments for drooling, and the place to start actually for drooling for a lot of people. So just to back up, part of the reason for drooling in Parkinson's disease is that your automatic swallowing is slowed down. Part of it may be that there's increased saliva production, but a lot of it is that automatic swallowing is slowed down. And so for a lot of people, if they have early and mild drooling and it's mostly during the day, sometimes chewing gum or a lollipop, or if you're not having a lot of choking and swallowing problems, sucking candy can be enough to get rid of drooling. If that doesn't work, kind of a next level of treatment is there are some oral medications, including atropine Drops, so these are drops that were initially developed for glaucoma, but if you put a drop under the tongue, can help dry out secretions. With oral medications, do have to be careful that with the drops and glycopyrrolate, sometimes it can cause other side effects. And there are also sometimes side effects to medications that cause dry mouth. So if people are having problems with drooling, I might pick an antidepressant or something else like that that has dry mouth as a side effect. And then the last treatment that's used is Botox injections into the salivary glands. And I guess for some people who have extreme problems, you can get surgical treatments or radio treatment to the salivary glands to reduce the amount of saliva produced.